first, what is nutritional epidemiology? Second, what are the criticisms to nutritional epidemiology? If we can reliably measure dietary intakes in individuals and populations, and finally, how to translate the science into the policy with particular focus on the food pyramids. So what is nutritional epidemiology? And I think before the pandemic, it was even hard to explain what an epidemiologist is. But nutritional epidemiology is a different specialty. So it examines the dietary or nutritional factors in relation to disease occurrence in populations. And it's also defined as the application of epidemiological methods to the study of how diet is related to health and disease in humans at the population level. It means it is directly relevant to human health. We study real life. We don't need to extrapolate from animal models or in vitro systems. And the results of our work can be translated into specific recommendations for changes in nutrient intakes or food consumption patterns. Why is nutritional epidemiology important? Well, according to the 2019 Global Burden of Disease study, dietary factors were the single leading cause of death around the world, in particularly in the map in the countries that you see in red. Switzerland, France, Japan, and Spain are among the lower affected, but it's still important to us. And the burden of malnutrition or overnutrition is even greater than the burden of smoking. So as you have seen, this is an important topic, yet there are several criticisms to the nutritional epidemiological studies. And I'm going to show you a TikTok, and hopefully you can see it.
5 small meals per day and run. Also eat 3 big meals a day and walk. Eat lots of protein. Don't do cardio. It's bad for your joints. You should know that cardio burns fat. Don't eat too much protein and get lots of sleep. But don't be sedentary, but don't be too active. It's easy, just eat vegetables. Fruit is obviously good for you, and also it's all sugar and bad for you. Speaking of sugar, I forgot to mention it's a vital source of quick-burning carbohydrates that your brain needs to survive, and you should avoid it at all costs. Drink water. Never starve yourself unless you call it intermittent fasting. Then it's okay to starve yourself a little bit. Fish is super good for you, and also it's mercury and it's killing you. And don't forget, get some sun every day for vitamin D and skin cancer.
Okay, so I just wanted to show you with the TikTok. Oh, let me change slides. So I just wanted to show you with the TikTok how the public perceives nutritional epidemiology and why it is so confusing. And no wonder why. Here I have you 2 different studies with very contradicting results regarding eggs, cholesterol from eggs and heart disease mortality. So no wonder why people are confused. They don't understand the differences in study designs, in methods, and sometimes how important it is a dose-response relationship, because most of the foods and nutrients that we study follow a U-shaped relationship with disease or with the outcomes that we study, so that too much and too little are bad, but there is like a sweet spot where we can find beneficial effects. So all this is confusing to the public, and it is our role to make it more clear to the general population so that they can understand the message of nutrition epidemiology. And what it's important to clarify is that research in nutritional epidemiology and in other topics is an ongoing process, and that the contradictions are inevitable and part of the scientific process. Not all studies are the same. As Professor Marquez Vidal in the last lecture, he introduced different types of study designs in nutrition epidemiology, but also not a new study does not kill the evidence from previous studies. So not newer doesn't necessarily mean better. And why it is so hard to study diet? Well, it is a complex exposure to study. So we in nutritional epidemiology, we study nutrients, we study foods, and we study dietary patterns. Nutrients can be highly correlated with another because they come from the same food sources. And some of them act synergistically. That means one helps the other to be absorbed, like for example, vitamin D and calcium, for example. And some of them act antagonistically. In this case, for example, calcium and iron, they compete for the same receptors in the intestine. Same foods with different preparation methods can have different effects. For example, the effects of filtered or non or boiled coffee on cholesterol. And eating more of one type of food can be compensated with eating less of another. This is why the studies, for example, of eating less fat, sometimes a diet that is lower in fat can be actually higher in refined grains. So these are details that one has to take into account studying diet. Moreover, we like the study of foods as part of a dietary pattern because it provides us the opportunity to study food and nutrient consumption as a whole, as the usual intake. And Professor Marques Vidal talked in his last lecture about dietary patterns quite a bit. So how do we weigh the evidence for nutritional studies? First, we need to ask, how was the diet assessed? And I'm going to talk in more detail about methods for dietary assessment later. What type of study design did they use? This was a topic touched by Professor Marques Vidal in the last lecture. It is important the sample size, how large the study is. Was it a study in animals or was it in humans? Not necessarily all the animal studies or animal studies results can be extrapolated to humans. Did they study real disease endpoints or markers for these diseases? And by this, I mean, we tend to study chronic diseases that take a long time to develop and sometimes they have low incidence. For example, we would like to study the role of a nutrient with breast cancer. Breast cancer would be the real disease endpoint, but sometimes the study will be too long or you will need to recruit too many people to do a study on breast cancer. So some people do studies on intermediate markers, for example, changes in the mammography reports. So this would be not the most perfect endpoint, but some intermediate endpoint. And then you have to put the results of each study into the entire body of evidence and how does it look in context. Now to the next topic, have you reliable measured dietary intakes in individuals and populations? Well, if we compare studying diet to smoking, it's a completely different thing. So most epidemiologists, or when you think about epidemiologists, you might think about the studies of smoking and lung cancer, those observational studies. And it's much easier to study smoking because you can ask people how many cigarettes they eat, for how many years they have been smoking. There are people who never smoked, people who stopped smoking. So there's even biomarkers for smoking. Whereas in the case of diet, everybody eats. So when diet is our main exposure, we have been exposed to it our entire lives. And it is in this relationships between diet and disease, we need to establish what are the relevance periods of exposure. This is difficult too. So the bad news is that there is no perfect methods. The good news is that we tend to use a combination of methods and statistical approaches to improve our accuracy and reliability of our methods. Rely on self-report and some of the objective methods. So the most used and also considered the gold standard are the dietary records, where participants record everything they eat or drink over several days. So when you have a multiple dietary record for several weeks, that will be the gold standard for dietary information. Now, you can think about this, and it has many pros and many cons. The pros is that it does not rely on memory because you are constantly writing what you eat. It can accurately ascertain detailed dietary information, for example, like the doses, or if you added extra salt, with what you eat it. It's open-ended data, so no matter what you eat, you can still add it to the dietary record. However, it provides a high burden to the participants. You require very motivated participants, of course, literate. It can be resource intensive, especially to take the information from those dietary records and convert them into foods and nutrients in your data. And interestingly, just the act of recording your diet can change how you eat. It's because you are more conscious about the things you eat. Another method are the repeated 24 dietary calls, where an interviewer will usually call on a random day the participants and ask them what they ate in the previous 24 hours. There is a component that it has to be a surprise day so that the participants don't change the information. And we try to usually do it including a weekend and a weekday, so that includes different types of diets, as people eat different things sometimes in the weekend. And this has also pros and cons. So it's accurate. It can collect detailed data, open-ended data. It doesn't have as much burden in the participant because they are being asked by the interviewer. However, it relies on memory. Now, try to take a few seconds and think about everything you ate in the past 24 hours. But maybe as a homework, try to, after this class, write down everything you ate in the past 24 hours. It requires for you some exercise of memory, and I'm sure you could miss many or some things. It depends on the interviewer's training, who needs to make sure that all these details are collected, but also should help you not forget certain foods and drinks, but also not prompt you to remember certain foods and drinks. So, and yeah, it's hard to have the perfectly standardized trained reviewers in a very large study when you have multiple interviewers. The next method will be the food frequency questionnaire. In this case, participants are provided a food list, usually with hundreds of foods, and they are grouped by the types of foods you eat, for example, breads, grains, desserts, and you have to report in categories that usually we include 9 categories, from rarely to up to 6 times per day. How often you ate these foods over a long period in the past. We usually take 1 year. And why do we take 1 year? Because this takes into account the seasonality changes. So sometimes if a person only eats strawberries in the summer, then you will have to do your own calculations and divide accordingly, so that it's an average over the entire year. So it's low participant burden and low cost, but this is in comparison to the previous methods, because in the studies I have worked, participants complain a lot about filling the food frequency questionnaire, and it takes about 40 minutes for an older person to complete a detailed food frequency questionnaire. The pro is that it captures long-term dietary intakes, which is what is important for us to do diet-disease relationships. And it allows repeated assessments over time. So usually the large cohorts have these questionnaires and they repeat them every 3 years or every 4 or 5 years. It is prone, of course, to recall error, because it will rely in how you remember what you ate over the past year. And it has a fixed food list. So it's possible that we miss some foods in our list. So I have seen cases where it's not adapted to the things that the exact population is. So here you can see in this example, they really try to put different types of bread so that there are no food omissions. So the classical food frequency questionnaire, let me go back, already has a size, the size of the bread, or a serving size defined. It will be a cup of rice, etc. But for people, it's really hard to estimate serving sizes. So some groups also provide the booklet with pictures, where people can use them to estimate if it was a small size, a medium size, a large size. And some of the food frequency questionnaires allow people to answer according to their sample size or the serving size of what they ate. So it can be a bit more detailed. Now, regarding the objective methods for dietary assessment. So these are the ones that do not rely on self-report, on written or verbal responses or the participant or a proxy. And they could be more accurate. They have they are less prone to recall error or the social desirability bias, where people report foods according to what they think the interviewer wants to hear that they are eating. However, they can be costly, they can be intrusive, and they can be burdensome both for the participants and for the researchers. So some examples of objective methods are direct observation, where you record exactly what and how much a participant eat. This is, for example, a study could be in food in cafeterias from universities or schools, where you could put cameras and film exactly how much people are serving themselves from the buffet. An interesting method that I think is not very much used is the duplicate diets method, where you have to collect doubles of everything you eat and put it in a bucket, and then you carry it around, and then they calculate the chemical compositions of your entire diet. Nowadays, there is more tendency to use the smartphone to record what you eat. And here in this method, they are using this app to take pictures of what they ate and what they left in the plate, and they need to add a small description because obviously there are things that would be hard to see. And they have these squares for size reference. And this would miss some things, like, for example, how much salt they added or some other details, but otherwise it seems to be a good method. Now, other non-subjective methods are biomarkers, and for that you need to collect biospecimens, that is blood, urine, but you can also collect finger nails cuttings or hair samples for certain minerals. And then you can assay the chemical compositions that reflect the dietary exposure, at least partly. And sometimes the biomarker results can be used to calibrate the self-report from the questionnaires that I have presented before. So the biomarkers may have different sensitivity and specificity, so the level of accuracy can vary. They may not represent long-term intake. They can be expensive and invasive if you take blood samples. And there are no biomarkers available for many nutrients. And in some cases, they cannot measure exposure. For example, in the case of calcium, and our blood levels of calcium are in constant homeostasis because they need to be at the same levels for us to function properly. So when we don't have a sufficient calcium intake, our body will take the calcium from our bones. So if you use a biomarker from calcium in the blood, it might not represent at all the calcium deficiency in your diet. Nowadays, we also are using high throughput methods that are called omics to assess a large number of traits, epigenomic, transcriptomic, proteomic, and metabolomic traits. Especially the metabolomics are very important for nutritional epidemiology because of the interplay between food and nutrition. And it can not only provide us as a marker of what they eat, but in particularly will provide us an insight into the mechanistic pathways of the diet-disease relationship. To date, there are no metabolomic markers that can accurately distinguish between most specific foods. And I just wanted to briefly introduce you to a study we're working at the Aging Research Group at BHAM about dairy and cognition, where we want to evaluate the role, study the association of dairy and cognitive function. And we will use metabolomics to identify markers of dairy intake in a subpopulation that has metabolomics data, in particularly those short-chain fatty acids that are part of dairy intake, so that we can evaluate this pathway as a pathway to the association between dairy and cognitive function. Now, let's talk about translating science into policy. So nutritional epidemiology aims to provide evidence for decision-making. And our goal is to improve health and well-being, as well as that's the goal of the public health research. And as Professor Marquez Vidal presented, there are not many large RCTs with hard endpoints. So most of the evidence that comes for decision-making will come from very well-conducted large prospective cohort studies and maybe smaller RCTs with intermediate endpoints. So some examples of how nutritional policy is done, we can start with education and awareness, that is the dietary guidelines provided by the government, the WHO, or the American Heart Association. Then we have labeling of nutrition facts in foods, but also like in restaurants, sometimes you can see in the menu the amount of calories and saturated fats they have. There are some economic strategies like adding taxes to certain foods, let's say sugar-based beverages, or subsidies to other foods, let's say vegetables or agricultural to provide subsidies to agricultures to make vegetables more affordable. Then we have fortification, for example, adding folate to flour. And then finally, one of the more strict would be banning certain foods, like, for example, trans fats. Now, in Switzerland, the Swiss Society of Nutrition has provided recommendations that a well-balanced diet is vital to promote a healthy lifestyle and influences our mental, physical, and well-being, and prevents and helps in the prevention from disease. Now, Switzerland has published the first set of dietary guidelines in 1998, and the current one is the third version and was introduced in 2011. This is how the food pyramid for Switzerland looks like. So you can see at the top, you have smaller quantities of sweet, salty snacks and alcohol, smaller amounts of oil, fats and nuts, 3 portions a day of dairy, fruits, meat, fish, eggs, and tofu, which is 3 portions a day of dairy is a bit higher than many other pyramids. Then you have 3 portions a day of grains, potatoes, and pulses, 5 portions a day of vegetables and fruits, and of course, 1 to 2 liters of water and physical activity. For some people, they will say that the pyramid is it's hard to understand for the general population. Some people criticize that usually what you see at the top seems to be the most important. Here it's just representing the quality, the quantity. But some people will think like, oh, the top must be, these are the best foods to eat. So sometimes a plate is also preferred to present these to the general population so that they can see in a plate if they more or less fulfill the recommendations. So how do you think Swiss people adhere to these recommendations, considering Switzerland is full of highly educated people and without average good socioeconomic status? Well, at the MENUCH, which is a study where Professor Marquez Vidal also takes part, they evaluated how the Swiss food pyramid was followed in Switzerland, and they found that only less than 1% of the population follows the guideline. And of course, then there is excess of the top parts, the sweet, salty snacks, alcohol, animal fats, a bit of excess of meat, and only 4 in 10 participants met 3 or more criteria, and only 18% of participants had more than 5 or more portions of fruits and vegetables per day. So this is interesting to see, and there were no regional differences in Switzerland. Now, when we talk about foods that are good for us, it's also important to talk about foods that are good for the planet nowadays. And the Eat Lancet Commission put together the top researchers in the world in nutrition and in environmental health, and developed the guidelines called the Planetary Health Diet. And then in this way, they promote a diet, a plant-forward diet, where here in a plate you can see is full of whole grains, fruit, vegetables, and nuts. That constitutes the greater proportion of the foods to be consumed and smaller proportions of meat and dairy. But above all, it discourages overconsumption, which can lead to obesity and food waste, and we don't want either of those. So what is the answer of what to eat and stay healthy? Well, according to this author here, it could be precision nutrition, which is part of the top recommendations of the NIH for research in the next 10 years. So the dietary guidelines I measure from the food pyramid are mostly based on population-based estimates, but precision nutrition aims to use individualized information from the people's genomes, microbiome, metabolome, to produce personalized dietary recommendations for chronic disease prevention and management. And it takes into account the interactions of nutrition with other modifiable exposures, such as the microbiome, the environment, physical activity, and others. So that might be the future of nutritional epidemiology and what you will see more in the next years. As a take-home message, just remember that the assessment of diet in free living individuals is challenging, but some methods can be used to classify people into different levels of intake, and we use different statistical methods to calibrate or adjust our results. The evidence of the role of diet of disease is an ongoing process, and as part of this process, there will always be contradictions. And nowadays we have guidelines that are based on the available evidence, the best of the evidence that we have today. So I just wanted to thank you, and we can open the room for discussions.
Thank you so much for this really interesting lecture, Mrs. Chocano Bedoya. I'm Lena, and I have the pleasure to lead today's discussion. And as always, I would encourage you to ask questions. You can type them in the chat and I will read them out, or you can just unmute yourself and ask them directly. And in the meantime, I would like to ask a question myself. It's more a general question, but I wondered, today and last week we heard how really complex and difficult it is to study diets and also to interpret the results of these studies. But in contrary, there are so much diets promoted in the internet or in magazines, and all these diets say, yeah, it's so easy, this is the best, this is the healthiest, yeah, just do this. And I wondered what the science or the policymakers could do to help guide the people through this jungle of diets and to protect them from unhealthy or maybe even dangerous diets.
That's a very great question. This is why I put the TikTok, and this happens to me a lot, that people think I can tell people what they should eat, and I always avoid to do that. I think there, as you mentioned, the general population is very interested in nutrition. They realize that it's a key modifiable factor. So I think the message is clear that diet can modify your risk of chronic disease. So this is why there's so much interest from the general population to it, but also there's so much consumption, so much confusion, and people are sometimes misguided and about it. I think it's part of the role, as I mentioned, of the government or for certain agencies to provide guidelines that are clear for the general population, to increase awareness and the level of education regarding nutritional research. And as I'm part of the Institute of Primary Healthcare, and I work with physicians. I'm a physician myself, and I think it's also a role of their primary healthcare providers, because as part of this Lancet Commission study that I showed from 2019, they also did a study of how much physicians knew about nutrition, and it was very little. So I take it as my role too to educate the young physicians I work with about the importance of learning more about this, so that they can consequently educate their patients.
So thank you for your answer, really interesting. I think someone wants to ask a question, or you just turned your camera on. Yes.
Thank you very much. Well, I also think that turning the camera on is nice, just to know people. So thank you very much, Professor Chocano Bedoya. My name is Hugo Santa. I'm a PhD student at the Institute of Global Health in the University of Geneva, and I'm originally from Colombia. I also work with a little bit and have been working some years with nutrition, and I think that your presentation was insightful. I have maybe 3 questions. I'm not sure if I can do the 3 questions. Please, Lena, let me know if someone wants to jump in. So maybe related to the measures, I wanted to ask you. I think that there is always a problem when some measures have been validated and we want to implement those validated measures in like our instruments in like other contexts. What do you think about this situation? So for instance, let's say that there is one instrument that has been validated in a different population and I want to use it here in Switzerland. That will be, do you think that we could, for instance, just implement this measure or this instrument that has been validated in a different population here? Or should we first do this kind of validation studies first in this other context? That will be my first question. I don't know if I should do the others just
I think
right
it's
away?
easier for me to answer the question by question,
yeah, okay.
so that then I remember what I wanted to say. I think it's an excellent question. And this happens, for example, for the food frequency questionnaire, because it has a fixed list of foods. So if you have a food frequency questionnaire that is validated in one population, it might miss some foods for another population. So usually there are studies, you start with a focus group to collect what foods you might miss, and then you run a new validation study so for a culturally appropriate food frequency questionnaire in the population you want to measure. So it's not a matter of translating, but you also will need to adapt.
Okay, thank you very much. And the second one is related to maybe these other more direct markers, and specifically talking about biomarkers. Do you think that when we are measuring biomarkers, there are like several possibilities, and usually when we are, for instance, measuring cardiovascular health and cardiovascular disease, there are these traditional biomarkers that have been used over and again in all of the studies. But some research have already shown like additional biomarkers that could be measured. But I don't know why in most of the studies they still use the traditional biomarkers. For instance, we are talking about HDL cholesterol, LDL, triglyceride levels, whereas there are some other studies that have shown that, for instance, measuring the apolipoproteins could give like a better measure of cardiovascular disease. What do you think about this kind of dichotomy that I find?
Well, I think one should not maybe exclude the other. Sometimes you want to do a study that can be compared to the previous study. So just for comparability, you try to run a similar analysis to the study before. To, let's say if you're studying nutrient A, you want to study now nutrient B, and you want to say nutrient B is better than nutrient A, so you try to follow a similar study design or a similar outcome, as you said. But I mean, of course, like we should always strive for the, as I mentioned, like the best outcomes. Pedro, maybe you want to add something to this.
Just a minute, yes. Well, regarding the market, for example, ApoA or ApoB, the European Society of Cardiology and also the American Heart Association do not recommend them because measurement is not standardized and depends on the antibodies you use, and it's also not available in many countries, and that's why currently the old markers are still the best ones, and it's very difficult, for example, to increase ApoA1. By the way, increasing HDL does not change your cardiovascular risk. It has been shown in randomized controlled trials. Whereas decreasing LDL cholesterol, irrespective of ApoB, does work. So currently, the guidelines are for the old markers because they have been proved to be more robust than new ones. And the main issue is the variability of the new markers.
Thank you, Pedro.
Thank you very much. I think that some people have other questions. I just have one more comment question. And it's related to the policy part. So when you were saying, okay, so the relationship with nutritional epidemiology to policy, I think that since, again, several years ago, we have a lot of recommendations from science that are actually not being applied in policy. And I think that there is a reason why, and this is especially related to the role of the private sector. How do you think that we should actually frame our results in order for being able of saying the private sector should change a lot their practices? Do you think that we can really actually do this? Because sometimes we are just focusing on the governments and saying, okay, government, you need to do that. But as scientists, we also have this role. So what's your perspective on that? And thank you very much for everything.
Thank you. I have to say, I don't work too much in policy. I'm a researcher, so I really try to help my research to be translated into things that will be policy later. But I'm aware of a long time ago that there was a scandal about that the food pyramids could be influenced by the lobbies, at least in the US, that the lobbies will influence what goes or what doesn't go in the food pyramids. I'm really not so familiar with the politics behind it, and I just think our role as nutritional epidemiologists is to provide the best evidence we can and to make it translatable to the general population and to the governments and organizations that they can apply them. And maybe it's the governments and organizations that they can negotiate with the private sector.
Thank you.
So thank you for these really interesting questions and answers. We have a question in the chat from Magda Gamba. She asks, what do you think is the current role of nutrition literacy to help population on applying the results of nutritional research?
Yeah, I think the answer is kind of what I said before. I think us as nutritional epidemiologists, as nutritional researchers, we are in charge of providing the best possible evidence for creating the policies and to be able to translate them into terms that the general population can also understand.
Thank you. Are there any more questions? I don't see one.
Maybe I can ask a question, just following up from what you said there about communicating things in the way that people understand. What are some of the ways that you could propose that this would be done? Because as you said yourself, and as we saw from this TikTok, maybe we have ways that people will definitely see the information, like if it's on TikTok, on social media, but maybe not, that doesn't necessarily ensure that they will actually understand the information that's coming to them. How can we make sure that the general public really understands this nutritional information easily without having a background in nutrition?
I think it's really hard. Like, for example, I was interviewed several times. I used to do research on premenstrual syndrome, and this was very popular by the media. And I found it really hard to translate, to make it, so I would say things like, iron is more bioavailable in meat, and people will be like, what is bioavailable? So we are really not trained to translate. We are so used to using this jargon, and I tried to explain that the study was done before they had, it studied incident premenstrual syndrome, so everybody was like, so it's really hard. I think it requires some training, so from our part, to make our research more in lay terms. So we had a course where we had to translate abstracts into lay terms. But also, like, I'm part of the Institute of Primary Healthcare. I really think it can go through the healthcare providers who have a direct contact with the person and can provide a more digestible information. I don't know, maybe Pedro also has some ideas from his point of view.
Hi, just a minute. Well, regarding health literacy, as I said in the previous talk, the issue is that it's mostly the more educated who will take the health messages, and the lowest educated won't. And there have been several randomized controlled trials showing that education relative to economical incentives, education fails in front of economical incentives. There are, at least to my knowledge, 3 randomized controlled trials where they showed that education, let's say, wanes after 6 months, whereas if you maintain economical incentives, people keep on eating healthily. So we talk a lot about education, but frankly, the more I work on on health and nutrition, the less convinced I am that this would be a very effective method. Sorry.
Okay, thank you for that. Perhaps I might also invite, I mean, I don't want to put anybody on the spot, but I also see that we have Magda Gamba here with us, who is also a nutritionist and was also at the expo in Dubai, and actually took part in kind of having correspondence on nutrition. I don't know, I just thought about perhaps directing this question also at you, because Magda Gamba actually delivered her research in nutrition in, I think, something like 3 minutes. So she was kind of involved in communicating her research in nutrition in a way that could be easily understood by people in just 3 minutes. I wonder if maybe you have also a tip for us, Magda. I don't know, I'm sorry if I've put you on the spot here, but I just thought, since we're on this topic of the discussion.
Can you hear me well, Emily?
Yes, I can hear you.
For some reason, I'm not sure if my camera works.
We don't see you, but we do hear you.
Okay, so, well, yeah, I think it's kind of difficult for us as researchers to think about how to translate these messages. And now I'm kind of sad and frustrated with what with what Pedro just said, that finding out that maybe you have to give people some kind of economical yeah, like money or something to make them eat healthy. So that's now running on my brain. But the thing, or the way I worked many years as a dietitian. So I used to work with patients and from all kind of socio-economical status. And what I could see is that sometimes they just needed, maybe we didn't spend an entire consultation explaining what was the diet, but maybe I just focused on something that they were kind of confused, and take the time to explain and I tried to find the best way with simple words, and I could see the faces like changing, like, oh, like a click somewhere, that they could understand why I was recommending to avoid certain food or to increase the intake of certain food. But this requires maybe also that we need to expand, as Dr. Chocano was telling before, from the clinicians, nutritionists working with the people directly, because we are like really in the background writing papers and doing the research. But for those people that could read, maybe they also need a train on scientific communication, because they read guidelines and they read very specific jargon, but they are the people that really need to bring that to the population. And maybe we cannot cover all the messages for a healthy diet, as the girl in the TikTok video, but maybe sometimes it's just one message that we could improve, that we could bring into the conversation, and that could help a lot, or that could make feel the person or the patient comfortable with what you're telling them, that creates trust, and they will come back to you and they will try to find more that or what you know, because they feel confident, because they feel you are speaking on the same level. So I don't know, that's what I think about it.
Yes, thank you very much. Thank you for that input. And sorry again to have put you on the spot, but thank you for sharing.
Thank you.
Nice to have had that kind of discussion. Of course, if people have any questions, as Lena mentioned before, please feel free to write in the chat or directly open your microphone so that you can ask your question directly. Whilst people are thinking of their questions, if I may, I'd love to ask another one, because as you were talking, Dr. Chocano of Bedoya, as you were talking about the family doctors needing to be able to explain nutrition and nutritional information in a way that can be understood, I was thinking about all of the other sources that people are now using instead of family doctors to get their information from. So I think nowadays we have a lot of these YouTube doctors, we have Google, we have influencers, we have all of these, we have online coaches, health and wellness advisors, and people are really reaching out to these, I would say, non-traditional experts. What can we do to kind of, because some of these things might be good, you know, but what can we do to kind of help people to identify who they should accept their nutritional guidance from? Because, you know, before we only had the doctors and it was very clear, okay, we go to doctors or we go to a nutritionist. But now, I mean, it seems like you have plenty of people available on YouTube or on social media who are also so-called experts in this field. Is there anything you could say to us about that?
I think it's really hard. I mean, can we really moderate? It would limit the expression, the freedom of expression, you know, like the way people, it was done a bit for the vaccines. I think if you mention the vaccines, then you will have under title that said consult, you know, like, but how much can you do it for other things? Like, I think in the case of the pandemic, it was sort of urgent to provide this sort of regulation, but still people felt like it was really limiting the right of expression. So it's a trade-off. And I think going back also to personalized nutrition, and it's a bit of epidemiology as well. It's like, a case, it's like a case report, you know, like people say to me it works, I don't know, to take a glass of warm water with lemon every morning. I lost 10 kilos, and you know, it's a sample size of n equals 1. And most people will not understand, and that, you know, what works for some people will not work for the others. And so yeah, I think it's really hard to regulate this.
Thank you. I see that Hugo also raised his hand. Perhaps you'd like to ask another question?
No, I actually wanted to say something about your question, because I think that there is an important issue related especially to influencers that are like usually like showing some practices, but then we can also use that in a different way. And I just wanted to talk about the last experience that we had in Colombia with the breastfeeding plan. We actually try to take like influencers in order to start promoting breastfeeding practices. So it actually worked kind of well, and this has been used like for one of the specific foundations that is working on the breastfeeding, the 10-year breastfeeding plan of Colombia. And I think that this is a way as well that we can engage people in like having different nutritional practices that. So, and it's also like a way of counteracting these probably bad ways of other influencers that are like showing other nutritional practices. And I just wanted to end up saying something that we are thinking about, maybe how do you say this in English? A specific segment of the population that is like very literate and all of that. And it's very important when we are trying to communicate nutritional guidelines to think as well like all of those other sectors of the population, especially those that are in like socioeconomic disadvantage. Because usually, and this happens a lot from the clinicians, we give some recommendations, but we don't think about the context of people. So we say, I cannot say to a mother of 3 children in Colombia that lives in Chocó, okay, so you have to follow these specific recommendations, dietary recommendations, but she doesn't have the ways of following those recommendations. So I think that it's very important to try to link both things, so the dietary recommendations, but as well the real possibilities of populations. But anyway, that was my input.
Yes, thank you. Thanks for that. Are there any more questions? Please feel free to unmute yourself directly or just to write into the chat. I see something in the chat here. Okay, no question, however. I don't want to dominate too much, but I have another question. And that was about, because we talked now a little bit about how different sources can be sources of information, nutritional information. Not all of them are as valid. One of the key sources for nutritional information at the moment is, in fact, mobile phone applications for nutrition for diets. So instead of seeing a nutritional expert or a family doctor or a person, they're actually just getting their dietary information and advice through mobile phone applications. You know, you have many of these types of diet apps like Noom. It's very big and very successful. Are there any drawbacks to such applications? Is there anything to be aware of? Because of course people are not getting interactions with other people, they're only getting interactions with text, with information which is popping up, and then based on that information they change their diet or their lifestyle. Is there anything to be aware of that people should be cautious of when they come across such applications?
Well, I think for the apps, at least in Switzerland, there are regulations, right? So for example, you create an app that, like the one I mentioned, that measures diet, you pass a certain types of ethics approval that is just for assessment. But if you have to provide advice on top of that, then it goes through a whole other process of regulating. It's considered a medical device. So then it's basically like introducing a medical device in the for the common population. It's way more controlled. So I have personally never investigated them deeply, but I would like to believe that if they are approved and regulated, probably the advice they provide is sound. Now, regarding the personal interaction, it might work for some people, you know, like for some people because of the constant, it's something they have on hand and they are, so it might, because it's also the frequency. It's not so easy, at least in Switzerland, it's not so easy to get contact with a nutritionist. You have to get a referral and sometimes it's not covered by your insurance. So it might provide an open door for people who have no other options. But as I mentioned, I'm not really so familiar with them.
Yes, thank you for that. It's a really good point to, as you say, to mention about how exactly certain countries, for example, in Switzerland, where not being able to see a provider directly may be an issue, then these kinds of alternatives could be something good to consider. Yeah, thank you for that. We only have a couple of minutes left, and that means I think we have time just for one more question. Is there a question from anybody? I'm just having a look at the chat. I don't see a question on the chat, but feel free now. Now is your time to ask the question if you have a last question. Okay, it looks like there are no more questions from the audience. Perhaps just to kind of conclude, because I saw that you had some take-home messages there. If we don't take anything else home from today, what would you like for us to leave with? What's the key thing that we should leave today with? If we can only remember one thing from today's, I'm sure we will remember lots of nice things because it's been very, very interesting. But if we can only take home one message, what should it be?
I think that the three take-home messages that I mentioned, that there are different methods to assess diet, that we use different methods. There are no perfect ways. It's impossible to conduct a perfect study, but we try to provide the best evidence as possible, considering how challenging studying diet and disease is.
Yes, thank you very much. We will definitely take this on board, and thank you once again for sharing your expertise and your knowledge in this field. And it's definitely been a very nice compliment adding on from our last week's lecture. So thank you so much for this very relevant, very interesting lecture. And thank you also to Lena, who guided our discussion time. It was much appreciated. So then, without further ado, I will bid you all goodbye. And before I do so, just a short note to let you know that next week's lecture will be on digital revolution and public health. And this will be brought to us by Dr. Valentina Rotondi, who's a researcher at the University of Applied Sciences in Switzerland and at the University of Oxford. So if that sounds interesting to you, then please join us for that lecture. We hope to have you there. And in the meantime, good night and hopefully see you next week. Thanks all. Bye.
Bye-bye.
Thank you.